members of the public who have joined us, that if you don't want to be recorded, please feel free to turn off your camera or to exit the meeting, and we'll be starting that recording shortly. We have no questions from the public in advance of today's meeting, and we have 4 members of the public signed up to join us. And our mirror board also receive a standing invitation. So thank you to members of the mirror board who are joining us today. Can I take us first then to our conflicts of interest register and any new declarations or declarations relevant to today's agenda? Looking around board members, and I'm not seeing any. Thank you. Our minutes of our last meeting was 21st January 2025, and the matters arising. May I have confirmation of accuracy or amendments? I'm just looking around our board. No, thank you. May I accept those as accurate? Thank you. And thank you to Alex. We note that you are camera off at the moment. Thank you. Today was our Chief Executive Fiona Edwards' last public board meeting in public. And I'm so sorry that Fiona's not able to join us, but I think that we can give our fulsome thank you even in her absence. So Fiona, is, you will all know, is now part of the NHS England regional team, and as part of that is part of the NHS England transition team, and so is in a necessary meeting this morning, given all the changes that we are seeing in the national context of the leadership of the NHS. We give again our congratulations to Fiona and our enormous thanks for all she has done to shape health and care locally, and thanks in advance for the shaping that she will now do nationally as well. So I'm going to hand over to our interim CEO designate, Sam Burrows, for our Chief Executive update. Thank you, Sam.
Thank you, Chair. Just a few reflections to share this morning with the board. So, as you rightly point out, this is our final meeting before our Chief Executive, Fiona Edwards, leaves to take up her new role as Regional Director for the North East of England. As an executive colleague, I just wanted to express my gratitude on behalf of colleagues in the board for everything that Fiona has done for NHS Frimley, the broader Frimley system, the providers that she has worked for in the Frimley system, and the support that she's given so many people across this part of the world over the more than a decade she has spent working in this geography. So a huge thank you from me on behalf of the team, and of course we wish Fiona good luck with the next step and her future endeavours as well. Clearly, it's been a really tumultuous few days for the NHS and people working within it. A range of announcements made last week regarding both NHS England and integrated care boards, which will have profound implications for the NHS and for this organisation as a part of the broader NHS construct. It is too early to know what the implications will be for NHS Frimley, and we are still working those through. However, the board should know that, of course, given how we've worked together over many years, we will do this in the right way together, and we will give thought and support to our people and our colleagues and how we best meet the needs of our residents as we work through this time of change. It's incredibly important that despite the unsettling nature of any changes which are to come, that we remain our focus on delivery and our focus on delivering against our strategic objectives to reduce health inequalities and to increase healthy life expectancy. That is our mission, and our mission remains unaltered as we work our way through these changes. As it is approaching the end of March, you will expect that work continues on planning for 2025-26 and the setting of budgets for the year ahead. The board should note that Frimley, as an ICB and as a system partnership, has submitted a compliant plan and is focused on the delivery of that plan across the year that is to follow. Finally, I'll just end by noting that since the board last met, we've had International Women's Day, which is a great opportunity for us to reflect on the importance of both gender equality, but also the contribution that women make, particularly in the NHS, as an employer and deliverer of one of the most important public sector services. And also to note that we're currently in the period of Ramadan, which we know is a hugely important point for our staff and our colleagues. I think we're around halfway through that, and of course we give thought to colleagues who are working through what's a really important spiritual journey for them as well, and the support that we provide during that period of time. So nothing else from me. Thank you, Chair, but happy to take any questions that colleagues might have.
Thank you very much, Sam. And may I open it up now for comments and questions? I think we all want to reflect how important it is, the leadership, Sam, that you and colleagues have shown in supporting all of our staff across the system during a time of uncertainty. And this has been very important for us, and the way in which our staff have really risen to the challenge is immensely commendable. Everybody saying we must keep our residents and patients at the heart of all our considerations and everything we're doing in this next stage, which is exactly as we would expect our culture to be. Sajad, let me bring you in.
Sam, thanks very much for the update the team have put through in these last few weeks and days. In the context of your comment about a tumultuous few days, how is the long-term work on the 10-year plan impacting you in the midst of all of these immediate kind of in-year challenges? And over the last few days, has there been any further clarity of how that long-term plan fits in with kind of the more short-term challenges?
Thanks, Sajad. Really good question. So clearly there are things that we know and things that we don't know around both what's going to happen in the year ahead, and of course the long-term plan is a part of that. What we do know is that the long-term plan for the NHS remains a flagship part of government's health policy, and nothing that's been shared in the previous 7 days would lead us to believe that there is any deviation from that. We are still expecting the long-term plan to be published in the early part of the summer, and we have a good understanding of, at a broad level, what we are expecting to see in the long-term plan, given it's an iteration of Lord Darcy's review of the NHS, which was published in the autumn of 2024. Now, clearly, the changes which were announced last week do give cause to question what now needs to be reflected in the long-term plan to enable the NHS to bring the correct level of definition and focus to what happens both this year and across the rest of that, what we're expecting to be a 10-year period that the long-term plan is going to set out. I'll be working with national colleagues to understand what can be shared ahead of publication to ensure that our thinking around how the ICB develops its response to changes that were announced last week can be best reflected into our thinking, and also looking forward to any further clarity that might be included in the long-term plan around the future role and function of the Department of Health and Social Care and ICBs themselves.
Thank you very much. I'm going to move us now to our leadership and culture section, and starting with our people and our EDI update. Over to you, Caroline.
Thank you, Chair. I'll cover the gender pay gap. Safina, I think you might cover the broader EDI update. I'll be short on the gender pay gap. Our remuneration committee has reviewed this report and supported its publication. It's a legal requirement that we publish annually our gender pay gap details. More than that, it's best practice to identify a action plan. So you'll have seen in the report we've produced the data as required, ready to publish on our website. And we've also gone into the detail of the associated action plan. We've reflected on last year's activities, and at that time we were going through and finalising our change programme. So a lot of the activities were focused in that change space. So just presenting this to the board, it has been agreed by the Remuneration Committee and will now next be published on our website. Handing over to you, Safina.
Thank you, Caroline. So just want the board to note the annual report for equality, diversity and inclusion, and that's part of our legal requirement under the Equality Act and the Public Sector Equality Duty that requires us to publish equality objectives, but also population data and workforce data around equalities. So the report provides an overview of the work that we've undertaken to demonstrate and provide assurance that we've discharged our statutory and legislative requirements and that we're compliant with the Public Sector Equality Duty. You'll see from the report that we have gone beyond compliance of our duty and really worked with partners across the system to showcase the collective what we have been doing to improve kind of equality outcomes for our population and our workforce, as well as building cultures of inclusion. So just over the past year, some key areas that we've highlighted, areas around policies and culture and practices, things like strengthening our recruitment processes through an inclusive recruitment toolkit to promote fairness, developing resources to challenging poor behaviours and culture. Obviously, we've launched the Mirror Board programme over the last 12 months as well, and that's really proving to support our enhancing of leadership inclusivity. And then we've introduced the anti-racism framework to address race inequality. So the report also includes our workforce race equality standard, and for the first time we published our workforce disability equality standard. So while we've got some progress made around these areas, we know there's some inequalities that remain, which have been highlighted in the report, and we've put an action plan together to address them. And they're mainly around representation, career progression, and some areas around workplace culture, specifically around bullying and harassment. So the board is asked to note we've produced that report in alignment with our duties under the Equality Act.
Thank you both very much. So one of the things that we had said as a board was that although we published various indicators at times over the year in relation to our culture and our staff, so gender pay gap, staff survey, etc., we would always focus on the coherence of our understanding of all these individual markers. So thank you for bringing that all together in this discussion. Alex, come in.
Thanks, Priya. I'd just like to make a comment, and apologies for my camera being off, but it's a really important time to reflect on the work that Safina and Fiona and the ICB and system partners have done in the equality space. It was never more important to bring this front and centre as part of the Frimley system way in terms of culture and behaviours. There's an attack on EDI globally. There is massive change for our people and our populations ongoing, and we must have our approach to growing and building equity front and centre to everything we do for our staff and our community. So just really want to commend the work that goes above and beyond just basic statutory duties, and it's great to see the impact we've had so far. I would just draw out a fantastic roundtable session on the anti-racism alliance that Safina has been developing, and there is public service partnership appetite to build this alliance, and we need to take this on as a system now. So just want to thank Safina for her work in this space. Thank you.
Thank you very much. Any other comments or questions? Thank you very much, everybody, for the work that's gone into all of this. It is the culture that brings us together across the system to make this collective impact, and it is really tangible for the Frimley system. So thank you. I'm going to move us now to our outstanding use of resources section and to our plan for the 25-26 year and the submissions that are being made for that year. So over to you, Rich.
Thank you, Chair. So the paper summarises the planning position and requirements, both operationally and financially. In terms of operational delivery, priorities are set out in referral to treatment times, in 4-hour waits in ED, primary care and dental access, and mental health patient flow and children's and young people's access. Excuse me. The paper describes the resources that are allocated to the system to deliver those operational targets, and essentially equate to a real terms funding reduction of 0.5% of resource available if one uses the NHS inflation figures as defined in the operational planning guidance. And current plans show an expenditure increase across the system of 10.3%, which is driven by inflationary uplifts, including pay awards and employers' NI, by statutory commitments, particularly in the areas of the Better Care Fund and Mental Health Investment Standard, and by the opening of new facilities, including M Block on the Frimley Park site. So the paper emphasises the need for close collaborative working to deliver the transformation programme to ensure the system both meets its operational performance requirements and does so within its available financial envelope. It will be a challenging year. The board is asked to note the latest version of the submission to NHS England, and further to note that an extraordinary meeting of the board will need to take place, hopefully on the 26th of March, in order to approve the final submission of the plans for the forthcoming financial year. I'm going to stop there, Chair, in view of the time, and I'm happy to take any questions.
Thank you very much, Rich, and thank you also to the board subcommittees for the detailed work that has gone on in getting our submission to this stage, and to the really productive work across the system that has allowed us to progress a plan of this strength, really. So to all of our system partners, and particularly to our FHFT partners, Lance and team, thank you. Can I open it now, please, to comments and questions from the board? I appreciate we have had significant discussion about this and the process by which it's been crafted and the sign-off process. So thank you. We are noting as a board the progress made, and that we are in a good position to make a final submission for board approval, hopefully on the 26th, and for submission on the 27th of this month. And this forms the basis of the work for our coming year. Thank you very much. And I'd like to move us now to delegated specialised commissioning services, and to you, Sam. Thank you.
Yeah, thank you very much, Chair. So board colleagues will be aware that specialised services and the commissioning of those services is a statutory duty that's currently held by NHS England, as defined by the legislation that was passed in 2022. The national intention at a policy level for some time that actually goes back to the point of that legislation being entering the statute book was to delegate responsibilities for the commissioning of these services to ICBs, and that policy has been iterating for a number of years now, which leads us to where we are today. The board should note this is a great opportunity for this ICB and ICBs more generally to take greater control and influence on how specialist services are both planned for and delivered for local residents. And I really commend the opportunity to the board today as another lever that will be available to us to reduce both inequalities in access and outcome and overall quality of care provided as well. Some ICBs have already undertaken the journey that we are embarking on. Some regions have gone sooner than ours. And for example, the East of England ICBs took this responsibility a year ago, and we've been working very closely with them to understand their experience of this change and to get ready for our own. For ICBs in the Southeast region, the target delegation date for this commissioning responsibility is the 1st of April 2025. On that basis, all 6 ICB boards in the Southeast region, of which we are one, either have met or will be meeting during the month of March to formally enact this policy and to enable this delegation to take place. The board should note that NHS Buckinghamshire, Oxfordshire and Berkshire West ICB met last week and approved the same ask that is being put in front of this board today. Clearly, we will have our meeting today, and there are 4 more ICB boards which are meeting between now and the end of the month. In order to enact this delegation, there are 3 documents that have been published as a part of board papers which this board is being asked to approve today. One is the delegation agreement. This defines what is being delegated and how that delegation will be compatible with the legal framework that exists for the commissioning of healthcare services more broadly. The assurance that I give the board today is that our legal advisors have reviewed this delegation agreement and are comfortable that what is being delegated and how the agreement governs that delegation is compatible with our own statutory duties and has been drafted sufficiently well that would give robust legal effect to this change. The second document that the board is asked to review is the collaboration agreement. This essentially defines how the 6 ICBs in the South East region will work together and with NHS England to ensure this delegation can operate effectively. The board should note that NHS Frimley have led on the production of the collaboration agreement on behalf of the 6 ICBs, and I give you my assurance as the interim chief executive designate that I am satisfied and comfortable that this agreement is compatible with how we wish to work and accept this delegation from April onwards. The third document presented to the board for approval is our interim governance proposal, which sets out for how, in a time-limited period at the start of the year to come, the 6 ICBs will work with NHS England to take decisions relating to these services on behalf of the 6 ICBs. By the end of Q1 25-26, my expectation is that this arrangement will be superseded by a new joint committee of the 6 ICBs and a joint subcommittee regarding specialist services, which will work to the joint committee to ensure we have a long-term and robust way of working collaboratively to ensure we take high quality decisions relating to these services. So in summary, the board is asked today to approve those 3 documents which would give effect to this lawful delegation of commissioning responsibilities. I'm happy to take any questions which colleagues may have, and that's the end of my presentation. Thank you.
Thank you very much, Sam. I open it now, please, to board colleagues for comment and questions. I think this has had significant discussion as this has been worked up. Can I take these requests then in order? The approval of the delegation agreement, which is at Appendix 1. Thank you. The approval of the collaboration agreement, which is at Appendix 2. And the proposed interim governance arrangements at Appendix 3. Thank you. And as part of this, I know, Sam, that we will be looking carefully at tracking the benefits to residents of this transition and the cost effectiveness of being able to deliver these specialised services to create the outcomes that we are looking for all populations across the South East region. Thank you very much. I'm going to hand now to our Chief Medical Officer, Dr. Lalitha Iyer, to lead us into our quality and performance reports. Thank you, Lalitha.
I think Sarah is here, Priya. It was meant to be me, but actually she's here, isn't she?
Ah, there you are, Sarah.
Yeah.
Yes, thank you, Priya.
Thank you very much.
I wasn't going to go through the whole of the report in detail. I was going to start on the planning and quality impact. I think it's the 4th slide down, Sam, to help you. I thought we would explain how we were planning. There we are. We were planning to do the quality impact in relation to the tight planning that we have to do this year. As you can imagine, there's an awful lot of looking at how people can change the way they do things across the system, making significant challenges. So we are asking individual organisations to look at their planning and the quality impact on it and submit quality impact assessments. And then, as you're aware, we have the system boards, and we'll ask the individual system boards where they have the expertise in the specific areas, such as mental health, children and young people, urgent care, etc., to look at relevant quality impact plans to the services that they oversee. And then we will bring together the system quality board to look at the totality of the impact for the system, so that we can be thoughtful and that one change or saving doesn't impact somewhere else. So we just wanted to bring that to the attention of the board. We were just sharing in the next slide around some good practice that we've had a system mortality review group for a number of years. The region have just started a regional mortality review group, and we were cited as an example of good practice that they were going to have a look at. And we use that group as a way of disseminating learning across organisations. And it's always a testament to whether a group is valued by clinicians or not, is whether they attend. And the RBH have voluntarily joined our system group for the last 2 years and are regular attenders, which is a good indication. Should we move on to the next slide? Just a little update on the vaccine programme, because I think it's one of our single most important things that we can do during the winter to help protect people, and well, more than just the winter, for health protection. Vaccine continues to be an area that we're challenged with post-pandemic, probably fatigue around vaccines. So we are re-looking and re-energising the programme this year to try and see what we can do differently. And then if we move down to the next slide, please. And then that takes us to, this is an escalation for the quality group for information, and we've escalated up to the regional group. And this is common across systems around the region and around the country. There was an MHRA alert that came out that everybody had to be compliant with last March, which no system has been able to be compliant with. It's around pieces of equipment that are issued out to individuals' homes and then keeping track of them after they're discharged from services. The MHRA alert indicates that you would need to have a system in place that regularly checks the pieces of equipment, and we are in the process of doing a risk analysis on this, but the cost of it versus the risk is undoable, and we would have to stop some services in order to be able to do this. We have completed a significant amount of work in this area, contacting any patient on the caseload, notifying patients by letter if there is anything with any piece of equipment that they're worried about, how to contact people and who to contact. But I think that's probably as far as we're able to go. But we are trying to work across the region to make sure that we've got a consistent approach. But I just thought the board needed to be aware of this. And then that's probably all I wanted to highlight. Oh, I suppose the only other thing to highlight in the report is Frimley Health had a CQC inspection that we've been expecting for a while on both sites. Both of their sites have now been visited, and we eagerly anticipate the report. No concerns were issued during the inspection, but clearly you have to wait for any report. So that's and we're waiting for that. And that was around their emergency flow routes, and that does corroborate with the regional report that looked at corridor care, that was very positive about both Frimley and Wexham Park, which is, it's nice to have that triangulation for the board. And that's probably all I wanted to say, unless people have got questions, Priya.
Thank you very much.
Sajid, Heatherwood's a cold site, so it wouldn't have, it doesn't have emergency facilities, and therefore it wouldn't be subject to the same flow from CQC.
Thank you.
Lance will give you a better answer, probably.
Lance, come in, and then Prash. Thank you.
Yeah, so just to expand on that, so the two inspections, the one at Frimley on the 4th and the 5th of February and the one at Wexham Park last Tuesday and Wednesday, were inspections undertaken under what the CQC colleagues call a system pressure performance inspection. So that focuses very much on urgent care flow, so the emergency department, and then they follow and track patients, key patients pathways through the rest of the hospital, most of which are obviously in our medical services. That doesn't stop CQC colleagues from coming at any other time, obviously, to inspect any of the other hospital services that we provide in terms of surgical services, paediatric services, women's services, etc. And those that we provide at Heatherwood. Heatherwood is, as Sarah just said, is an elective only facility. Just building on that very, very quickly, the verbal feedback for both was positive. We're waiting, as Sarah outlined, for the formal reports. We are expecting the formal report for the Frimley Park site in between 2 and 3 weeks' time for factual accuracy checks. So it should be made public in about 4 or 5 weeks' time, and then about 5 weeks after that, we should be able to make the Wexham Park, or receive the Wexham Park report, and then make that public as well.
Thank you very much. And come in, Prash. Thank you.
Thank you, Priya. Thanks for that, Sarah. It was just a sort of comment, and it's good to know that there's going to be some work done on, obviously, the vaccine fatigue, the vaccination fatigue, should we say. It's so important. We've got a government that talks about prevention, and I know that colleagues have talked about what is prevention, and as a clinician, prevention takes so many forms. But whatever we can do as wider system partners and local authorities, maybe engaging with our communities. There's so much good evidence when it comes to a successful vaccination program. Children who are vaccinated and fully comply with vaccinations, they halve the number of visits to primary care and/or ED. The evidence is stark. And when you look at our at-risk communities, you can see that the pressures in ED, that the people that end up in corridor care, who have got either influenza or COVID. It's not rocket science. You can see that in our most deprived communities where vaccination rates are lower, these are the people that get ill and then end up in these areas where care can be complex and challenging. So certainly in primary care, we are going to keep maintaining our efforts with regards to really encouraging our communities to come in and get these preventative measures that we know have a real cause and effect. Whatever wider system partners can do, and whatever influence we have with regards to encouraging our public, the very public who are concerned about where people end up when they're sick. But here is a very simple way of avoiding problems if we can somehow get that narrative out and say, actually, high levels of prevention by something simple as attending vaccinations is powerful when it comes to actually not putting pressure on our hospital services. So it's really encouraging. Certainly this is something that I know that the board takes very seriously. I know the board is really, really targeted on helping and encouraging areas of inequality where vaccination rates are low. And it's just really good to see that even despite vaccination fatigue, there is a clear plan to really tackle this, because it's that upstream prevention for something very simple that's going to help us avoid some of those pressures downstream. But thank you for that, Sarah. Really powerful to see those figures and obviously where the hard work needs to be targeted.
Thank you very much, Prash. Any final words, Sarah? I shall move us on then to our next item. Really grateful for our this item, which is the Assertive Outreach Programme. And Graham Wareham, Chief Executive of Surrey and Borders Partnership, is going to lead us in this discussion, a key discussion for all systems across the country in these days. Thank you, Graham.
Thanks, Priya. Yeah, I mean, I think we've all been doing, well, in Frimley, Berkshire Health and Surrey and Borders both been doing the same work, which is basically to look at patients and people supported by our community services and divide them up into cohorts of people and how risky they are. And this is with a particular attention to people who are likely to disengage from services and make sure that they aren't discharged from service, and we're actually assertively outreaching to support them. So I think, broadly speaking, all mental health trusts have gone through the same process to make sure we're keeping people safe. And I think then in the year ahead, we'll be continuing to develop community services to have much more assertive outreach offer. But that will be part of the development work that we go on in the future. But this has been the immediate learning that came out of the CQC inspection of the Nottinghamshire Trust. I was going to stop there, Priya, unless there's sort of more that people want to know.
Thank you very much. Alex, did you want to come in before we open it up to questions?
Thanks, Priya. Just to say, Berkshire Healthcare's board took in public our action plan in relation to this, well summarised in the ICB paper. And this is about working with our existing workforce to bring the focus that's needed to this cohort for support and need. There was some hope there may be additional funds, but given the context of finance in the NHS, that's not so. So it's about how we shape our approach to individualised care, careful discharge planning, and support and advocacy in the community. So we're providing the best care we can for these individuals. Thank you.
Thank you. And can I open it up to comments and questions from the board? Safina, please come in.
Thanks, Chair. It was just a comment really in terms of, or maybe a question, how this links in with the wider kind of patient and carer race equality framework, providing kind of cultural competent services and all that equality, you know, all the inequalities we know around mental health and kind of ethnic diverse communities. So it was more of a quick comment, I think, rather than a question. But if there's anything you can answer, that'd be great.
If I could come in, Priya, I think the patient care race equality framework drives directly at the individualised support and understanding of needs for all members of our community. There are a number of initiatives going on for mental health services, including our work in Berkshire Healthcare on Mental Health Act detentions, directly linked to PCREF, and the Culture of Care programme that draws in anti-racism and culturally competent development of our inpatient services. And that will, of course, also link to our community support.
And Graham, did you want to come in?
Yeah, I mean, I think it's the same, really. I mean, we're all implementing the patient care race quality framework, and as Alex has said, that different cohorts of protected characteristics are overrepresented in different issues. So we need to take this population health focus to think about how we tailor our services to deal with different problems in different localities. So that's part of the implementing the race quality framework, which all mental health trusts are committed to doing.
Thank you. Ilona.
Thanks, Priya, and thanks, Graham, for bringing this to our attention. It was really interesting and reassuring to read. Just a quick question. I'm guessing it might be quite tricky because some of the outcomes here might be harm avoided, but are there plans to kind of evaluate the impact of rolling out this approach more widely?
Yeah, that is a good question, Ilona. I think it's about, I mean, I think we've all got outcome frameworks that we've implemented across mental health. So I can't recall, Alex will probably remember, well, we'll know obviously what Berkshire are doing, but in Surrey we're doing, Surrey and Borders, we're doing dialogue. So, but that's looking at all the care you receive. So assertive outreach is a sort of, it's a process you're doing for an at-risk cohort. But in terms of the outcomes, that would be managed through the dialogue paired scores, which look through a range of different measures: housing, employment, your health, and you're looking to show improvement, of which assertive outreach would be one component feeding into that. So it wouldn't be, I don't think it will be measured in its own right, but we might look at it in the course. I don't think we've thought about whether we do that specifically. I don't know what Alex thinks.
Similar holistic outcomes measurements for all of our impact, including recovery. I think we've obviously got to track carefully the actions we're putting in to address this high risk, high need community of patients. But we do need to take a holistic view across all patients in terms of outcomes. We will have a similar methodology to dialogue in Berkshire.
Thank you both very much. Let's move then now to our finance and performance report and to Rich Chapman. Thank you, Rich.
Thank you, Chair. So the performance report in the papers shows the month 10 financial position. That's as at the end of January. It showed, can we just move on one slide, if that's okay? It shows a system deficit of £7.4 million at the end of January, which is a 3.5 million adverse variance from plan. That variance is improved by 2.1 million since month 9, and the system is forecasting that it will reach break even after the application of £25 million of deficit support funding for the financial year. The system's assessment remains that figure, the deficit support funding, constitutes the financial impact of inefficiencies caused by the presence of rat concrete at Frimley Park Hospital and the costs of the associated mitigations. If we just move on the slides, please, and on one more. Thank you. So capital on this is for the ICB. The ICB identified funds for minor improvement grants, was not able to deliver all of those schemes within year, and has recycled the capital underspend into project proposals to improve general practice IT in a range of areas, and Lloyd George scanners for the digitisation of clinical records in primary care. At the time of writing the report, the ICB was still awaiting approval from NHS England. That has now been received, and the projects are being progressed at pace with purchase orders generated, I think, today. as we are meeting. If we can just move on to the performance slides, please. One more. Thank you. So ED performance, 4-hour waits were at 75% in January against 78% target. This is largely demand driven, and the 62-day waits are at 72%. Now that figure is heavily impacted by dermatological cancers, and the position is expected to recover in February. The slides detail the risks and actions being taken to mitigate those risks on the right hand side. If we can just move on to primary care performance, please. So same day appointments are slightly up year on year at 85% against 83% for the corresponding period, which was December 2024. And we're slightly down year on year on 14-day appointments at 90%, but both figures, both the 90% this year and the 92% last year, were above the national target. And that essentially a large part of our ability to deliver timely access to primary care is predicated on our use of digital technologies, and that is reflected in the face-to-face appointments, where we are at 52%, which is below the England average, and that is simply a trade-off of access versus timeliness of access versus face-to-face. If we move on one more slide, I think we'll find learning disabilities, mental health, children and young people. So only 36% of early intervention psychosis patients entering treatment have waited less than 2 weeks, and the portfolio is taking actions forward with our providers as a matter of urgency. There remain 10 inappropriate adult acute mental health out of area placements as at December 2024, and there are a range of significant actions being taken to address that situation, including the exploration of the development of a mental health virtual ward and the funding of a social worker to complement the Hampshire Isle of Wight discharge team, which is the geography that faces the most significant challenges in maintaining patient flow. In terms of long-term resolution, the housing needs assessment for 2025-30 has been completed, and that will play into the system's developing estates and infrastructure delivery plan as we move forward. I think that completes the integrated performance report. If we can take that down, I'm happy to take any questions. Thank you.
Thank you. Very clear, very helpful. Should we have the workforce report as well? Ilona, come in first, and then we'll bring in the workforce report as well.
Oh, sorry to jump in. Rich, thanks very much. I just noted under that last page on children and young people's mental health, the middle KPI at 36%. In the narrative on the right-hand side, it said it might be a data quality issue. I just wanted to unpack that a little bit, because obviously it's a worrying statistic in itself, but equally, if we're not sure we've got a handle on our performance in a data sense, that's worrying too. So I wanted to flag concern with that and just get a bit of assurance around next steps, please.
Yeah, so the portfolio are reaching out. I think it's at BHFT where the performance is kind of is materially below the level that we need. And I know that conversations are taking place with BHFT, and it's to be honest, it's not uncommon to find data quality issues in these types of areas. So we need to be sure whether the situation that the data is currently presenting is true or not first, before we move on to take action on it. But essentially, we're just describing that we are on that, we are cited on it, and we are taking appropriate action.
Thank you. And could we have the workforce report, please, Caroline, and then we'll come round to comments and questions in relation to all of those.
Sure. Thank you very much, Priya. Thank you, Sam. If we let's move on a couple of slides. I'm hoping colleagues have had a chance to read this. Our first slide is the performance against plan. So this is the 24-25 period. You'll note that this is month 8. There is a time lag on data publicly available and when that's produced. But you get a sense of our providers and their relative performance against plan and strengths, particularly on absence, vacancy and turnover levels. Next slide, we then move to understanding the position on temporary staffing. I've provided the board here with an overview as we host the temporary staffing collaborative that runs across all 27 trusts in the South East. This is a one-pager on the performance across the South East at month 9. Just to bring to your attention, the team run projects across all 27 trusts, and down the left-hand side there's a summary of the projects under the programme. The one where the programme board, which actually meets this afternoon, is focusing down on is the medical staffing project that we will roll out and intensify support to trusts. I'm particularly flagging that one as locally FHFT colleagues, SABP and BHFT are all very focused on that one, particularly FHFT colleagues in improving our performance against not just plan in year, but for the coming year. Next slide, please. These next couple of slides, if we just flick through the couple of slides on primary care, please, Sam. So colleagues will have seen the sort of headline metrics that we present and report on at month 10 on our primary care workforce data, and the sorts of questions that the team and team of teams focus in on in terms of our primary care workforce data and associated areas of focus. Next slide, please, Sam. That's the last one on the R's roles and sort of transparency of our performance by PCN against allocation and delivery of those roles. Next slide, please. The Frimley Academy, uniquely the Frimley system, our ICB hosts and delivers through the Frimley Academy programs focused on system leadership capabilities. So the flagship programs around 2020 and Wavelength continue to draw colleagues to these programs year upon year, well evaluated. The board may recall that we took a bit of a deep dive into the work of the Academy a couple of months ago, and we're certainly now reviewing, in light of the anticipated changes ahead of us as a system, the focus of the Frimley Academy resource and those programs in support of the transformation, and particularly the support for system leadership as we take the very positive of potential new build facilities within our patch. How can the Academy continue to support system leadership development in support of that opportunity? Last couple of slides, please, Sam. So I just wanted to focus on the staff survey. The results of embargo on the results have now been lifted. At the time, we could share with you this, our ICB staff survey results, but colleagues on the call, FHFT, SABP and BHFT have all had their staff survey results. Our System People Board will meet, and one of the items this month is going to be just reviewing across NHS organisations on our patch, our staff survey results, the learning from that, and how we use that data to inform the work of the System People Board. I just wanted to give a particular shout out to FHFT and BHFT colleagues. One of the sort of key metrics is around staff agreeing it's a good place to work, and you'll see from perhaps some of the published data now on FHFT an increase in the number of staff, and indeed Frimley as one of the top 5 acutes in the South East in terms of staff saying it's a good place to work. And a further improvement BHFT colleagues above the national average in terms of staff recommending it as a place to work. For our ICB, lots to draw from. There's a lot of bullet points here, but whilst we run through the detail of this, we'll be looking at our OD plan in light of what our staff are saying and the job ahead, and where do we need to support and work together as an organisation to increase. But a shout out, I think, for we're a small organisation, but my heart is warmed, and it's great to see improvement around questions, particularly relating to our compassionate culture, and that our staff outperform the average in questions relating to feeling safe to raise concerns. So lots to take out in terms of the positive, but also a very laser-like focus on what it is that staff would say we need to improve in the ICB. We have some teams that are outliers in terms of their experience, and a particular area of the quality of appraisals that will, whatever happens over this coming year, we'll be focusing in on good development conversations for our people. Last slide, thank you. I'm just going to zip through the OD plan. I was just giving the board assurance on that we have a good, really good OD plan, and that obviously in light of both the staff survey results and what's ahead of us, we'll be refreshing and reviewing that. We move on, Sam. Just skip over these the OD plan slides, please. Thank you. Work well, assurance there on our flagship work on supporting our residents into work. Great programme of work, small, very small and agile team. I'm going to bring back to the board another time a bit more of a deep dive other than these bullet points that give you assurance that we're on track. We've been getting some very good feedback from DWP and the DHSC team that are frankly that are oversighting this to say, hang on, you're up to good things in Frimley, we want to take another look. So we've got a bit of a visit coming from DWP colleagues and others to say, that's interesting, what are you up to? And we like the shape and the focus of your work programme. How are we delivering against the targets to support nearly 4,000 residents in terms of working well? I think I'll draw it to a close there. I think the last slide was just a standard slide on the ICB metrics on our workforce profile, much like we show for FHFT and other colleagues. I'll close it there, Priya. Thank you.
Thank you very much, Caroline. Really helpful updates. Colleagues, any comments or questions? Caroline, I will ask you now to take us into our board assurance framework review, please.
Thank you. Sam, I won't put anything up on screen. Thank you. Colleagues, I hope you've had a chance to read the report. The main change since obviously we review our board assurance framework regularly, the main change I wanted to flag to board was the change in risk profile for our leadership and culture strategic objective. That is now out of risk, and there's a very short explanation there of under leadership and culture, we have the commissioning hub delegated specialised commissioning functions to the ICB. Now, earlier on in the agenda, we signed off the next stage in terms of that delegated commissioning. And in the body of the report, you'll see the assurance around our management of that set of risks. I believe that we will be able to mitigate that particular area of leadership and culture to bring it back in risk appetite over the next quarter, but reflecting the significant amount of work in that space in our strategic objective around leadership and culture on delegated commissioning. That's what's caused the shift. Just to note that as a board, we will be reviewing in Q1, so in April, May, probably the May board, the risk appetite statements, and keeping a regular eye on our BAF. The ICB internal auditors have issued a final board assurance framework and risk management report for 24-25 with reasonable assurance ratings. Again, board asked to note that, and that we will, as I say, review those risk appetites, statement and risk thresholds for the coming year ahead.
Thank you very much, Caroline. Comments or questions, colleagues? Sajjad, come in.
Just Ilona, feel free to add, just at the audit committee, a couple of additional focus areas in light of recent events. So there was another ransomware attack against the NHS in the southwest and southeast at HCRG. That's a supply chain, another supply chain following Synovus last year. We've asked kind of at the audit committee for a bit more detail around that so that we can kind of get into that a little bit more in terms of understanding the residual risks, especially through the supply chain. And obviously, as we start to adopt more digital and AI tooling, what are kind of how we're managing the risk option of that. So just a couple of extra things just to make the board aware.
Thank you very much. And Ilona, did you want to come in?
I mean, we had a good discussion about the BAF at the last audit committee, which was just last week. I don't think I've got anything to add to what Caroline has helpfully covered off already, and Sajjad's supplementary comment there as well. Thank you.
Thank you very much. Good. Okay. Our next agenda item is questions from the public, and today we haven't received any questions. So I will ask board colleagues whether they have any other business. And I'm seeing shakes of head. So we are next meeting in public on the 20th of May at 11:30. Thank you very much to everybody that's attended and to board colleagues. Thank you.
Thank
Bye-bye.
you.
Thank you.
Thanks, Priya. Bye.
Thank you.
Bye.